20. But I think Madam will invite the first presenter. Please strictly stick to your time, and we will conduct the session now. Thank you.
First presenter again, Srima Bansal. Yes, okay. Yes, good afternoon, everyone.
So it has started with fireworks now.
So, first paper by SARS-CoV-2 in conjunctival swabs, delayed or prolonged shadings than in nasopharyngeal secretions. Chief and presenting author Dr. Rima Bansal.
So, a very good afternoon to all of you and respected judges and panelists and dear friends. Thank you for allowing me to speak with a changed order. And I'll be presenting my work on detection of SARS-CoV-2 virus in conjunctival swabs, delayed or prolonged shedding than in nasopharyngeal secretions. So I'm thankful to our entire team at PGI. It's a multidisciplinary work, huge work that was possible with the help of departments of ophthalmology, virology, internal medicine, intensive care, medical microbiology, and amongst them all our residents who were posted in the COVID ward and collected these precious samples. So the background was why we conducted this study was a wide range of positivity rate of SARS-CoV-2 has been reported in ocular samples varying from none to 28.57%. So what was not known before this study was what is the viral load in conjunctival swabs as compared to the nasopharyngeal swabs, and what is the clinical significance of its presence in the conjunctival secretions, and what is the infectivity of the conjunctival secretions. So the objective of this study was to detect the presence of SARS-CoV-2 in conjunctival swabs of COVID-19 patients and to compare their viral loads with those of nasopharyngeal swabs. So these were the patients of COVID-19 disease who were hospitalized in our institute PGI. We followed the ICMR guidelines, and after approval of IAC committee, the conjunctival swabs were collected from these patients and transported in the VTM tubes, followed by their storage in the Department of Virology. These were used for RNA extraction to be done for RT-PCR using the Q-line kit. This kit uses open reading frame 1 and nucleoprotein gene PCRs, and the CT values are used for knowing the viral loads. CT value of less than 40 were taken as positive and more than 40 were taken as negative, and the details like date of sampling and the CT values of baseline nasopharyngeal swabs were retrieved from the database. Coming to the results, 17 patients out of these 93, that is 18.27%, demonstrated this virus RNA in conjunctival swabs. The baseline nasopharyngeal swab collection took place at a median of 2 days within 0 to 7 days, and the conjunctival swab collection was delayed at a median of 7 days, ranging from 1 to 25 days from the onset of illness, and this was significantly different. Despite this significant delay in the collection of conjunctival swabs, compared to the nasopharyngeal swabs, the CT values did not differ in these 17 patients between conjunctival and nasopharyngeal swabs. The two groups of conjunctival swab positive and negative, however, were comparable in terms of age, gender, the degree of COVID-19 disease severity, the days of sample collection, systemic comorbidity, use of immunosuppressive therapy. However, there was a higher mortality rate in the conjunctival swab positive than conjunctival swab negative group, although this was not significant. So this is just to show the number of 17 patients who were conjunctival swab positive, and I just want to show you that since at that time there was a protocol of repeating nasopharyngeal swabs during their admission, we found that out of 17, 14 underwent a repeat nasopharyngeal swab, and out of these repeat, the green highlights that these had turned negative at the same time when the conjunctival swabs were being reported as positive. So the evidence so far is that the conjunctival secretions and tears from patients with SARS-CoV-2 infection contain the virus RNA in the presence as well as in the absence of ophthalmic symptoms, and there is lack of elucidation on the viral RNA dynamics in the conjunctival swabs as compared to the nasopharyngeal swabs. So the strength of our study is that this is the largest series of conjunctival swabs samples tested. This is the first to compare the CT values of conjunctival versus nasopharyngeal samples. We included patients of all disease severity, Most of the previous studies have included patients with more severe disease, and we had a wide range from onset of disease, including 0 to 3 days, whereas most of these studies have used the sampling only in the early stage. So the limitations of our study are those of a typical of a cross-sectional study. We didn't have a longitudinal follow-up. We could not follow a fixed day schedule for collecting the conjunctival swab from every patient, and we did not compare the lab profile, although we compared the demographics and the clinical details between the conjunctival swab positive and negative patients. So the conclusion is that this study provides us the potential of the conjunctival swab samples to detect the virus in mid-phase or even the late disease. The positivity of conjunctival swabs when the nasopharyngeal swabs are no longer positive may suggest that there is a delayed or a prolonged shedding of the viral RNA on the ocular surface than in the nasopharyngeal mucosa. This certainly may have some prognostic implications and may need to be considered in the discharge policy of these COVID-19 patients hospitalized. Thank you very much.
Questions? Yeah, obviously. Thank you, Rima, for your nice presentation. You said the conjunctiva is positive and negative.
Yeah.
How many are nasopharyngeal positive
They were all
between the two?
They were all nasopharyngeal positive because they were diagnosed COVID-19 on the basis of a positive nasopharyngeal swab.
No, but in one of your conclusions, you said when it was negative.
That was the second consecutive sampling, because at that time the guidelines by the Ministry of Health and Family Welfare were that before discharging the patient, we have to take the second consecutive nasopharyngeal swab of the patients. So this was the time when we were collecting the second swab during their hospitalization of the nasopharyngeal, and these turned negative, and this was at the same time when we were collecting the baseline conjunctival swabs of the patients. So we found that the second sample of the nasopharyngeal was already negative as compared to what the conjunctival swab was positive.
What was the reason for this positivity when the nasopharyngeal is negative and conjunctiva is positive?
So the reason is that this suggests that either the virus is getting transmitted to the ocular surface late, it is probably coming from a retrograde transmission from the nasolacrimal duct after affecting the nasopharyngeal mucosa, or probably it is shedding intermittently on the ocular surface, which is not getting detected early, and it tends to remain on the ocular surface for a much longer period as compared to the nasopharyngeal.
Could it have been a larger series?
Sorry?
What were the constraints? Could it have been a more number of patients?
We could have had more, but we completed with the 93 samples.
Okay.
Thank you, sir.
So I request the second presenter, Chief and Presenting Author, Dr. Shriksha Kumar K, for his paper. I'm sorry.
Good afternoon, respected judges and my dear friends. My paper is on a comparative study between autologous blood serum alone and with cauterization for graft fixation in the management of pterygium. So we all know conjunctival autografting is the gold standard in the management of pterygium. However, graft fixation is equally important. We have tissue glue, sutures and autologous blood fixation for fixing the graft. However, autologous blood is comparable to other modes of fixation. There are chances of increased recurrence when the comparative study has shown increased recurrence with the autologous blood grafting, and that is because of graft loss, and an additional fixation of the graft using a tuck-in fixation or grafted cauterization has been tried in this particular paper. And we included 112 eyes of 110 patients. So we divided them into two groups. So the group 1, which included 55 eyes of 55 patients, and group 2 included 57 eyes of 55 patients. And the first group received autologous blood alone, and the second group autologous blood with the graft edge cauterization. And we included patients with progressive pterygium, symptomatic patients with primary pterygium, and those with cosmetic reasons, and recurrent pterygium, double head pterygium, and patients with filtering blebs and glaucoma suspects were excluded from the study. And the follow-up period ranged from 12 months to 48 months, and the average follow-up was 16 months. And this is the procedure. All the patients, the surgery was done under infiltrative anesthesia, and this is a tuck-in procedure. Autologous blood is used for graft fixation, and the slightly oversized graft was tucked in under the cut conjunctival margin. And at the end of it, the stability of the graft was checked by moving the lid against the graft. This is the second group where the procedure was done under infiltration anesthesia. Subconjunctive injection of lignocaine was given, infiltrated, and gentle cauterization was done. A thin graft, a slightly oversized thin graft was taken, and the graft was placed on the bare scleral bed with a thin ooze, and it was fixed to the cut conjunctival margin using bipolar cautery. And this bipolar cautery, this thermal cauterization actually causes coagulation of the conjunctival proteins, and thus helps in adhesion of the graft to the bare scleral area. And the stability of the graft is checked at the end of the procedure. All the patient has received post-operative antibiotics, steroids for 1 month. And the results, the duration of the surgery was slightly more in the group 1, which received autologous blood with the tucking in fixation. This could be because of the weaker fixation, and the surgeon tried to stabilize the graft for a longer duration, and it's almost 1 minute more than the grafted cauterization group. Coming to the complications, 4 patients had graft loss, and of these 4 patients, 3 had recurrence. And in the group 2, 2 patients had graft loss, and 1 patient had recurrence of the pterygium. Retraction of the graft was seen in almost 50% of the patients in the group 1, and it's around 22% in the group 2. Other complications were almost equal in number in both the groups, and which had no significance as far as the outcome of the procedure was concerned. So autologous blood graft fixation is there, and we have been using it for graft fixation. It is cheap and it is safe, easily available. However, the graft fixation is weak, and chances of graft loss and graft retraction is more common with the autologous blood fixation. And a bare area is a potential source of conjunctivalization, which can cause recurrence. So, an additional step of cauterization which can reduce the chances of graft loss or graft retraction, and thus it can reduce the recurrence, can be tried, and it is safe and very effective in managing pterygium. Thank you very much. These are my references.
Yeah, I will. I will. In your the indications for pterygium excision,
Yeah.
one thing is grossly missing is the refractive error. It is one of the high astigmatic index, and the reduction of visual acuity is the indicator for graft removal, or the conjunctival pterygium removal.
Yeah,
Why you have not considered that as your this thing? And 2 videos which I have seen, the pterygium is very minimal, and whenever you touch the pterygium like that, there is high chance for progression actually. That's what happened in your cases. Retraction also
we
has
have,
happened in
yes,
your
sir,
cases.
yes, sir. We have not included large pterygiums grade 3 and above, and we have not included recurrent pterygium. Thinking because these procedures, the fixation is weak as compared to glue or sutures. So purposefully we have not included them in these studies. It's a simple pterygium grade 1 to grade 2, and primary pterygiums were included in this study.
How many of grade 1 and grade 2 will you go for surgery?
These are all the patients who actually were willing for the surgery. Grade 1, grade 2 with minimal astigmatism, and patients come for cosmetic reasons also in our setup.
No, what was the refractive index you are getting in these patients? Do you have the refractive index of these
Refractive error.
refractive errors? Yeah.
Yeah, no, like
The
we
readings.
even combine cataract with the pterygium.
Your
but
data
of
is
course
showing
here we
that.
have not included them. Those who are having the refractive error of less than 2 diopters, so we have even combined with the cataract surgery, the
Now,
phacoemulsification.
did you show that data now?
No, here it is not there. It is not included in this study. But we have done a phaco with the pterygium study, wherein we included patients with less than 2 diopters of astigmatism.
Okay, thank you.
Thank you, sir.
You were, no, no, other people. You want to ask any question?
No, no.
Thank you.
Thank you, sir.
Yeah,
Third.
next.
Yes, I would like to Hello. Next speaker, Dr. AIOC2022.
Confirm your AWS membership because the award is only given.
Want to use my laptop actually, it's not working here. I want to use my laptop because it's not working here. The video is not running. The topic which I am going to discuss is pterygium extended removal followed by minor ipsilateral simple limbal epithelial transplantation, also known as slit for recurrent pterygium. It's just a thought process that I'm going to share with you all. I'll be covering this topic under, we have done this procedure in 6 of our patients. This is patient 1, 61 years old female, a known case of recurrent pterygium with symblepharon. She was operated twice elsewhere, and she is also a known case of primary open-angle glaucoma in both the eyes. So is there any answer to that? Because she was quite adamant that she doesn't want any further pterygium surgery. So there is an answer when we can treat her with almost zero recurrence in a patient with primary open-angle glaucoma. And the answer lies in the perfect technique. So when we reviewed the literature related to the perfect technique, we found an article from Dr. Hurst from Australia, and he did this surgery in 1,000 patients with just 1 recurrence. So we were quite not only alarmed, but quite happy also. Then we looked into the cases of recurrent pterygium from his own series, and we found that there were none recurrence in a series of 101 consecutive patients. But is perfect technique advisable in our patient who is suffering from primary open-angle glaucoma? No, because we need to preserve the conjunctiva for future trabeculectomy if required in this patient. So we modified this perfect technique to slit, where what we did, we took the per of perfect, that is, we did the pterygium extended removal, and then we replaced the later like fact with the slit, that is slit. So that's how we innovated this technique as slit. So this is the surgical technique. I don't know why it's not working. Just one second. So this is the technique. You can very well appreciate that there is an extensive symblepharon here. We remove the pterygium from the head end. And here is the symblepharon release, that's what we are doing. This is the you can very well appreciate that there is an extensive fibrosis in this patient, and we are removing this extensive fibrosis. Now we are removing the entire tenon, and you can see that there is extensive fibrosis between the conjunctiva, tenon, and the underlying muscle, that's the medial rectus. So we need to identify the medial rectus. We have to remove all the fibrous tissue surrounding this medial rectus. We need to remove it till the medial canthus, because we all know that it is the tenon which is the source of the recurrent pterygium. And then we are making the fornix. This is the fornix forming suture. Now this is, till this time, it is the per of perfect. That's what we did. Now we have placed the amniotic membrane over it, made it adhere to it with the fibrin glue, taken one clocar of limbal piece, split it into 4 pieces, placed all the 4 pieces at the limbus at the site of the pterygium over the amniotic membrane, and made these pieces adhere to it with the help of fibrin glue. And then we place the amniotic membrane. So if you see, this is the post-op day 1. All the 4 pieces are well there. This is day 7, day 4 weeks, and there's a 6-month photograph. So we started our journey from here and landed in this manner. Even we are not finding now the ocular restrictions, even the symblepharon is not there. Subsequently, we did it in 5 of our more patients. We found there is a non-recurrence in any one of them. Even we did one patient with double-headed pterygium, as you appreciate here, and there was no recurrence at 6 months. So it is basically the compulsion from the patient that led us to think about this permi-slit. What are the pros of this procedure is, it's a complete and extensive removal of pathology that's being done here with preservation of conjunctiva, and we have even taken the anti-inflammatory property of amniotic membrane into it, and moreover, we have replaced the pathologic stem cells with the normal stem cells. Of course, any surgery has hindrances, and we got the exophoria and granuloma, but what is most satisfying is that there was no recurrence, no symblepharon, good cosmesis, no ocular restriction, and we have preserved the conjunctiva for future trabeculectomy, that's glaucoma surgery. So take-home message is, that's a promising technique. It has the ability to change the practice pattern, and of course we need a large cohort to finally conclude our results. Thank you.
Thank you.
Next author, hello. Next speaker, Dr. M. Banathi.
Presenting author is Dr. Prithvi B.
Presenting also, okay. Okay. M. Banathi first.
Present a clinical trial which was done using a topical autologous platelet lysate. It's a drop used in chronic ocular GVHD as an adjunct therapy. Graft versus host disease. This is the immune response which has been between the donor tissue against the host tissue, where it is limiting the utility of the allogenic stem cell transplant, which is the only available treatment for the benign and malignant hematological conditions such as AML, aplastic anemia. Whereas ocular GVHD affects the productivity of the person. Chronic ocular GVHD accounts for around 60%, where the symptoms as a wide spectrum, where minimal involvement causes redness and photophobia, whereas an extreme and it can cause non-healing ulcers, stromal thinning, necrosis, stem cell deficiency, and even perforation. Conventional treatment, what we have is the lubrications and other supportive measures which do not address the root cause. The steroids and immunosuppressive has some benefit, but it has long-term side effects. There are so we needed some solution which address the root cause and which is permanent. There are some evidence which is showing that their biological replacements such as serum eye drops and platelet-rich plasma and platelet lysate drops, which can be used for severe refractive ocular surface pathologies. They contain growth factors and also anti-inflammatory mediators, whereas platelet lysate contains growth factors which is readily available because of lysis of the platelets. Growth factors has been readily available for the action. Till date, there are few international studies, and there are no Indian study based on GVHD or the use of platelet lysate. There are studies which is showing significant improvement by the end of 6 months objectively as well as symptomatically in GVHD patients, where they have used serum eye drops as well as platelet lysate. There was one study by Gabriel et al. Where confocal microscopy was used to assess objectively, which showed significant decrease in basal epithelial cell density, which is actually increased in dry eye disease. My objective was to evaluate a topical autologous platelet lysate as an adjunctive therapy in a severe refractive chronic ocular GVHD. It was a non-comparative study. Actually, I recruited 14 patients. We were 18 years and above with severity grade of more than 2 to 3, with platelet counts of more than 1.2 lakhs, without any systemic illness or infection, without any systemic infection. Among them, 2 expired because of the severe systemic involvement. 4 didn't follow up because of COVID. I could follow up only for 8 patients for 6 months. Where autologous platelet drops were prepared by using blood of a patient. I draw 100 ml of blood, which was centrifuged to get platelet-rich concentrate, which was frozen for minus at 20 degree for overnight and thawed in the morning to lyse the platelet, which was prepared in 20% solution, made into 5 ml vials. 4 vials were given for the patient for a month. One which has been used was kept in the freezer at freezer door at 4 degrees. The other drops were kept in freezer. They were evaluated at baseline 1, 3 and 6 months, where objectively symptomatical evaluation was done by ocular surface disease index questionnaire, and objective evaluation was done by staining of cornea, conjunctiva, hyperemia, and also the lubrications used at different period were taken into account, where it's reduced in number, and also the steroid use. Age, they were ranging from 18 to 54 years, and the second graph showing the time of recruitment from the onset of the disease. You can see the median time is around 270 days. It indicates that the disease has set in and there is no response for the usual conventional treatment. You can see that 80%, majority of the eyes showed significant improvement symptomatically by the end of 1 month. Although the objective signs were improved in few patients by 1 month, the majority eyes, around 60%, showed improvement by 6 months. The individual parameters, if we analyze, it was a non-parametric skew data, so we used Wilcoxon sign rank test. There was significant improvement of ocular surface disease index scoring, symptomatic scoring, and also the tear breakup time, conjunctival staining, and also the frequency of lubrication was reduced by the end of 1 month. The corneal staining and shimmers showed significant improvement by 3 months. The visual acuity was also shown to be improved by end of 1 month, and also the conjunctival hyperemia, which was severe by at around for the 62 patients, which was reduced to 6%, and 62% didn't add any hyperemia by end of 6 months. I analyzed the severity used based on NIH, DUCE criteria, also international criteria. All three showed there is significant reduction in the dry eye disease by the end of 6 months. Tear protein analysis and also MMP9 levels were analyzed using the ELISA technique, which didn't show significant. Statistically, they were not significant. This may be because of the small sample size of 8 patients. My limitations were the sample size, which was only 8, and it was non-comparative. Long-term follow-up will be required to see for the late responders, and also if there is any treatment failure. Standardization of the growth factors were not done, which will we can actually tell the every patient is receiving the same amount of growth factors. To summarize, the improvement of symptoms were by end of 1 month, and objective signs were improved by end of 6 months in majority of patients, with decreasing frequency of lubrication and also the steroid administration. All the grading systems showed significant improvement. So I conclude that APL drops serves as an effective biological replacement therapy, which can be used for refractive GVHD patients. Large sample size will be required, which can, with the standardization of the growth factors in the APL drops, along with analysis of the biochemical markers.
Thank you, but it's a good study. Actually, idea is good, but major objection is 3 patients. It should have been presented as a poster. But you need to continue this as a long term, this thing, and you cannot conclude with 3 patients.
No,
anything.
it's 8 patients.
8 patients.
8, but effectively 3 patients.
No, it was 14 patients I recruited. Among them, 8, 6 months follow-up was done.
Out of that 3 patients data only you have.
No, sir, it was 8 patient total.
Okay.
8 patient total.
Data is of 8 patients, but I think we need to go ahead with double blind study to
Yes,
prove
sir.
the efficacy of this particular treatment modality.
We
that
actually
is
thought of giving approval all the patient, because none of the patient was satisfied with the usual treatment, so everyone were requiring some intervention. So we thought of giving to all the patients.
Yeah, but analysis is also required, biochemical analysis in these
Yes, sir.
patients. What you are using, how much is it effective, and what is the quantitative growth factors that are really available for the patient?
Yes, the standardization.
That is also needed in
Your concept is excellent, but you need to carry it forward. I
Yes, sir.
think.
Thank you.
anyhow it is possible in our patient. Thank you.
Next presenting author, Dr. Pragya Panda.
Respected judges and delegates, a very good afternoon to all. My topic for today's presentation is ophthalmic manifestations of mucormycosis, a prospective study. Mucormycosis refers to a rare, severe opportunistic infection with fungi of the order Mucorales. Mucorales have an intrinsic ability to invade the blood vessels and can evade the different parts of the body. Cerebro-rhino-orbital mucormycosis is the most common and the most aggressive form. Uncontrolled metabolic conditions, especially diabetes mellitus, is the main risk factor. Mucormycosis is a rare fungal infection, and the incidence in India is much higher. Affected individuals may have poorly controlled diabetes, metabolic acidosis, or immunocompromised. Mortality remains high despite advances in diagnosis and treatment. We have studied 11 cases of mucormycosis, out of which 8 had orbital findings. Detailed history taking ophthalmic examinations were done. A visual acuity slit lump examination, intraocular pressure measurement, contrast enhanced CT scan, MRI orbit was done. Associated systemic examinations were also done. Temperature measurement at regular interval, urine examination and blood sugar test was done and the results were analyzed. The ophthalmic presenting features were lid edema was present in 8 cases, chemosis, periorbital edema, facial edema and discoloration of the lid, discoloration of face was present in 4 cases, proptosis in 6 cases and ptosis in 3 cases. Ocular motility restriction was one of the common presenting feature, 6 cases, and ocular pain was present in 6 cases. Associated systemic features were COVID-19 history was present in all the 11 cases. Uncontrolled diabetes mellitus in 5 cases and controlled diabetes mellitus in 3 cases. Malignancy was not associated in our study and poor general condition was found in 1 case and hypertension in 3 cases. To record the visual acuity, more than 6 by 24 visual acuity was found in 6 cases, 624 to 3 meters in 6 cases and PL negative in 4 cases. This is one of the case of mucormycosis. The patient was seriously, the patient which had low general condition and much lid edema and proptosis, chemosis, gross restriction of ocular movement was there. This patient actually succumbed to the general condition. Now about the management of the cases, retroorbital amphotericin B was given 3.5 milligram per ml in 6 cases. Liposomal amphotericin B was given. Pre-medication of injection Avil and paracetamol was given. First dose 1 ml containing 1 milligram without pre-medication. Hypersensitivity reaction was watched for 30 minutes and then 1 ml of retroorbital injection containing 3.5 milligram of amphotericin B was given. Posaconazole was tablets were given 300 milligram 2 times on day 1 and 300 milligrams OD on day 2 onwards to all the cases. Exentration of orbit was done. Entire eyeball and the surrounding structures including muscles, fat, nerves, eyelids were removed. Dressing of the orbital cavity was done frequently. Skin grafting was given and posaconazole tablet 300 milligrams twice a day to start and then 300 milligrams OD were continued. This is a case of mucormycosis presented with restriction of ocular movements and ocular pain. Patient was COVID positive 3 months back. Following 3 months of COVID, the patient became COVID negative. After that, the symptoms started. CT scan of the orbit revealed orbital mucormycosis. These are the restriction of ocular movement and mild proptosis was there. Only on CT scan, it was diagnosed to be mucormycosis. Following exentration, this is the photograph following exentration of the orbit. The nasal cavity and because it started, the patient first presented to the ENT department where the debridement of the sinuses were done and then exentration of the orbit was done, which was life-saving. So exentration of the orbit was done and debridement of the sinuses. So it took a combination of ENT surgeon and ophthalmic surgeons. To conclude, rhino-orbital cerebral mucormycosis is a severe opportunistic infection. The destructive exentration is life-saving. Retroorbital amphotericin B and posaconazole tablet is also helpful. Thank you.
Thank you. You did not mention about the paranasal sinuses which are
Yes,
affected in all
actually
this.
to start with, it was a paranasal sinuses. The patient presented to ENT department to start with and then they gave us a call
I
that to see
understand
the
that,
orbit.
but in your presentation, none of the slides showed involvement of the paranasal sinuses.
Yeah,
That
yeah.
is what I want to point out. The number 2 is the terminology of destructive exentration is not good. You can say radical exenteration rather than
Okay.
destructive. It is not
Okay.
destructive.
It's
It is life saving,
life
right?
saving, yes. Thank you.
I request the next presenter, Chief and Presenting Author, Dr. Mrs. Kasturi Bhattacharji, for her presentation.
Respected judges and ladies and gentlemen, I'll be speaking on platelet-rich fibrin as three-dimensional structural scaffold in the surface unhealing or the eye and the orbit. And we have no financial disclosures, no conflict of interest. We all know that a platelet-rich fibrin, also known as PRP, is a second-generation biomaterial wherein autologous platelets and leukocytes are present in a complex fibrin matrix to accelerate the healing of the soft and hard tissue and thus used as a tissue engineering scaffold. So during the reparative process, we know there are a wide range of intra and extracellular proteins working along with the growth factor. Though the understanding of this entire process is very complex, however, platelets play a crucial role not only in the hemostasis but also in the wound healing. We all know this that platelet-rich fibrin, also known as PRF, serves as a simple, non-toxic, biocompatible and economical therapeutic alternative which bears the potential for steady local release of growth factors, making it a holy grail for the future medical and pharmaceutical research. We know that PRF is a second generation fully autologous biomaterial which has got numerous growth factors like the platelet derived growth factor, the fibroblast growth factor, the transforming growth factor, the VEGF, the epithelial growth factor, the insulin growth factor, and the mesenchymal stem cell. So all these growth factors along with the fibroblast and the leukocyte, they make a matrix, and this enhances the tissue regeneration by entrapment and sustained release of the mesenchymal stem cell, thus preserving its paracrine function. So the aim of the study is the evaluation of the platelet-rich fibrin as an adjuvant in the surface healing of the eye and the orbit. This is a prospective non-comparative intervention study where 14 patients were included, 8 with the contracted socket, 2 with the non-healing late fistula, 2 with a wide conjunctival granuloma, and another 2 with the late cicatrix. History and examination was done thoroughly as per the prefix pro forma. And following the reconstruction, PRF was incorporated as a layered surface adjuvant to the buried wound, and the wound assessment was done by the wound evaluation scale, which is a validated scale by the Quinn et al., which has been validated by the American Emergency Academy. And the PRF has been prepared by drawing the autologous blood, and the clot activator free vacutainer is being used, which is centrifuged at the rate of 3000 rpm per minute, and this is a PRF which we get. The top is a PPP, that is the platelet poor plasma, which we discard. The central is the PRF and the rest is the RBC. So we had done the follow-up day 1, day 7, 1 month, 3 and 6 months, and at the end of 6 weeks, 3 months and 6 months, we have taken the wound evaluation scale and taking 6 attributes: the step of borders, the contour irregularity, the scar width, the edge inversion, the inflammatory changes, and the overall appearance. 6 is a very good score showing a very good healing, and 0 is a worst score. So once the PRF is obtained, the acellular plasma can be squeezed out to yield a resistant fibrin membrane, which is a multilayered membrane and placed as a layered adjuvant to catalyze the wound healing. And as mentioned, all healing has been graded as per the wound evaluation scale. And if you look here, this is the PRF that has been used, and this comes with a plasma. So we need to squeeze out the plasma, and this is an autologous fibrin with full of growth factor which can be used for the healing process. And this is, you can see where it's a very bad late cicatrization where full thickness blepharotomy has been done, and you can see the PRF has been sutured to form the posterior lamellae. So 2 ml of blood will give us a PRF sheet like this. So if I have a 10 ml of blood, I get 5 sheet like this, which really can form the posterior lamellae very well, as you can see how I'm suturing the fibrin mesh. So this is another case of the socket where I have been using, this is a PRF as it is healing, and you can see how the socket reconstruction can be done. As you can see, the pre and the post-operative and intraoperative with the PRF. So at the end of the 6 weeks, out of the 14, 12 had a score of 6 by 6 and it's only 2 had a score of 4 by 6. But these 2 patients were lead fistula with excessive granuloma. And this is a very nice socket healing that you see at the end of the 4 weeks. But interestingly, what we see that at the end of 3 and 6 months, all the patient had a healing of 6 by 6. And the one who had a 4 by 6 and 1 month has healed up well within 3 months. So I like to mention that PRF, by virtue of slow polymerization, confers an intrinsic structural scaffold for the incorporation of platelets, the growth factors, the cytokines, the leukocytes, and the circulating stem cells. It is an autologous, economical, and easy to synthesize layer healing conduit. And the study reveals that PRF would provide a prudent physiological three-dimensional fibrin reservoir for the cytokine enmeshment, the cellular migration, and the sustained release of the growth factors, which can expedite their own healing. To the best of the knowledge by different search engines like PubMed, the Google search, the Science Direct, the Scopus, Cochrane, we found that this is the first of its kind to showcase the utility of PRF as a prudent physiological fibrin reservoir that can expedite own healing in surface reconstruction of eye and ocular orbit. Thank you very much for your patient hearing.
Thank you, Kasturi. It's a nice idea and presentation as well. For me, orbital reconstruction is a large area, and how could you arrive that this is the size and this is what the volume I want to prepare? Because you need to pre-prepare this.
Yes, this is an interesting question because we all know that maximum amount of 1 unit of blood donation is 350 ml. So we were thinking, and even if I take a 10 ml, so if I put a 2 cc tube, I get a sheet, one sheet. So with 10 ml blood, I can have 5 sheets like this. So sometimes what happens in bad socket contracture, doing only a phonics forming suture or dermis fat graft does not help. We need to just have another layer of mucous membrane, which we take from lips or from the buccal mucosa. So if you have something or an amniotic membrane, which is so economical from your own blood, so and as we can take almost 10 or 20 sheets like this, because 20 cc, it can be given very easily.
Yeah, briefly you have mentioned the sizes of the sheet and the amount that is required for this thing. So, what is the average of the sheet breadth and length that is required? Did you calculate that in your
Yes,
cases?
this depends on the size of the test tube. If this test tube is 2, and we all know that a 2 millimeter test tube has an overall size of 1 centimeter. If it is 10, we get an overall size of 4.5 to 5 centimeter. So depending on the size of test tube, in our centrifuge, we can put both 2 cc test tube and also the 5 and 10 cc test tube. So sometimes we just take 10 ml too, because we need 2 test tube to balance each other. And so we get a 4.5 to 5 centimeter sheet, especially in a bad case of dermis fat graft. But if it's a lid, we just take 2 cc test tube. So we get around 1 centimeter sheet.
Preoperatively, what I am asking is, preoperatively, by seeing the patient, you say that this is the estimate of the sheet size that I require because of these parameters, and I would like to have this amount of ml of blood that is centrifused, so that I will have an adequate sheet while doing the peroperatively, so that you need not look for additional sample.
Yes, minimum we take 10, so we get 5 centimeter, like 1 centimeter, 5 sheet.
Thank you.
Next presenting author, Dr. Pooja Khamar.
Good afternoon. At the outset, none of the authors have any financial disclosures pertaining to this study. Ocular surface disease or dry eye is becoming a pandemic. Approximately 344 million people worldwide are being affected with dry eye disease or ocular surface conditions, and approximately 50 to 60% of them go undiagnosed, affecting the productivity and the quality of life. Stratifying these patients at the right time is very important to give them optimal management and the patient satisfaction. If you see, if you consider a disease and you treat them with X treatment, you will have three groups. One who respond to treatment with no side effects, one who do not respond at all, and third group who is responding partially but have stronger side effects. These are the two groups we need to look at because they need some other therapeutic options. But if we can identify at the right time that what is affecting them, we can give them optimal treatment. So what do we need? Dry eye at this point of time is diagnosed based on the clinical signs and symptoms. But TFOS currently updated the classification saying that molecular biomarkers would help be the correct treatment strategy for these dry eye patients and have optimal outcome at the correct time. But why biomarkers? Because biomarkers can help in differential diagnosis, patient or disease stratification, risk stratification, prediction of disease progression, and they also help in determining the progression of the prognosis of the response to the disease. Current data workflow for biomarker discovery works in such a way that you need a laboratory setup or you need to be collaborated with a laboratory. And the turnaround time for this test is days to months. Also, we should not forget that there is a cost of setup and to the patient when you do such a test to identify a biomarker. So our research question was that like COVID-19 and other life-threatening conditions have taught us the power of rapid diagnosis. We also wanted to know that can we have a tier-based point-of-care diagnostic kit in our clinics to diagnose this ocular surface condition. But for any biomarker discovery or any kit, you need to choose the right biomarkers. Our group and various other groups across the world have been studying biomarkers across various diseases starting from the cornea film to the brain, and we decided to look at all the literature and choose the most common biomarkers to incorporate in the kit. Some of them being IL-6, IL-1 beta, IL-10, TNF-alpha, ICAM1, IL-17A, MMP9, and VEGF. We decided to use this common biomarkers and build a ELISA-based, fluorescence-based microfluidic device, which is based on the antigen-antibody reaction. The antibodies are present in the well, which you can see here, and the antigen comes from the tears or the aqueous humors of the patient. The added advantage of the kit is it has a secondary monoclonal antibody present in the well here, which is present in the buffer solution. And which increases or enhances the sensitivity and the specificity of the kit. We use this kit for different disease conditions, controls, dry eye, keratoconus, glaucoma, and diabetic retinopathy patients. We collected tears using the Schirmer strip, and they were subjected to the point-of-care diagnostic kit. We collect the tears using Schirmer strip, like how we do a dry eye test, and rather than discarding this strip, we collect it in an Eppendorf tube after a 5-minute period, and then we add an extraction buffer solution of 300 microliter, and then we take 500 microliter and put it in the cartridge to put it in this kit, which is the analyzing system. By the end of the 60-minute test, we can run 32 tests in one cartridge. We get the range of the biomarkers for each of the eye, right eye and the left eye. And based on the reference interval, we can see whether it's a normal or an abnormal biomarker and how we treat each of the patient accordingly. Coming to the MMP9 levels, which is the major biomarker in our kit, we had different groups as mentioned, controls, dry eye, and keratoconus, and which were diagnosed based on the TFOS due to guidelines. In MMP9 levels, according to the literature and our studies published, any levels of less than 50,000 picograms per milliliter is considered normal. But surprisingly, what we found that this control patients, in spite of having no signs or symptoms, in their tier markers, we found that the MMP9 levels were higher. More than 50,000, and some of them had even more than 1,62,000. So we labeled this group, in spite of being normal, as subclinical inflammation 1 and 2 group. And if this is the Schirmer's test TBUT and OSDI scoring of this patient, that they were normal, even if the patient have a control subclinical 1 or 2 inflammation group, the Schirmer's 1, TBUT and OSDI score were completely within normal limits, but the MMP9 levels were on the higher side. Not just MMP9, but IL-1 beta, IL-6, IL-17A, ICAM-1 and TNF-alpha were also found to be on the higher side, suggesting of subclinical inflammation, proving the same. When we compared the same cohort with the keratoconic eyes, we found that the MMP9 levels in the keratoconic eyes were on the higher side, but the other biomarkers like IL-6 and other biomarkers were not significantly higher in keratoconus group, which were higher in dry eye disease group. How do we apply this to clinics? If the patients have any signs and symptoms, and if their MMP9 levels are on the higher side, if they are normal, you just give an artificial tear drop. But if they are higher, you first treat them with the cyclosporin drop. But if it's more than 1,50,000, you right away know that in addition to a cyclosporin drop, you will need a modern day dry eye therapy as well. We do know that some patients in dry eye, evaporative dry eye disease, they do not respond with cyclosporin. Why? Because they have higher levels of ICAM-1 or higher levels of one of these markers, which will not respond to cyclosporin, and they will need a lifitegrast-based eye drops or a steroid-based eye drop or a modern-day dry eye therapy. Why is this important in our cataract refractive surgery or any patients? Because if the patient has subclinical levels on the higher side, and if you do a surgery on them, post-surgery they'll have a poor wound healing, which will lead to poor quality of vision. To conclude, this is the first panel in the world in eye with multi-marker strategy to define severity and customize the treatment. It helps in monitoring the response to the therapy and prevent undesirable consequences. Thank you.
Next speaker.
I invite the next speaker, Dr. Minu Ramkrishnan. Dr. Minu Ramkrishnan,
Absent.
Chief and Presenting Author. Okay. Dr. Minu Ramkrishnan.
Absent, no? Next.
Next paper, Chief and Presenting Author, Dr. Aditi Pal. Aditi Pai. FP1515 absent.
A very good afternoon, everybody. I'll be presenting on the topic novel approach of retrobulbar amphotericin B to tackle orbital mucormycosis. I have no financial interest. Mucormycosis is transmitted by inhalation of spores or by direct inoculation of the spores into the disrupted skin or mucosa, which leads to a high mortality among immunocompromised by alteration of their immune system. India was badly affected by the second wave of COVID-19, causing a high mortality in immunocompromised, mainly post-COVID-19 and diabetic patients. COVID-19 pandemic has witnessed a resurgence of the cases of rhinoorbital mucormycosis. This study documents these cases and their management with this novel approach of retrobulbar amphotericin B in halting orbital infections. The study was carried out for a period of 8 months at our tertiary hospital from Jan 2021 to June 2021. It's a prospective interventional institutional study, and the enrollment was carried out till the end of June 2021. Thereafter, a minimum follow-up period for 60 days was taken. Informed consent was obtained and approval of local ethics committee was obtained. A positive RT-PCR reaction of nasopharyngeal or oral swab with history of COVID-19 were confirmed. A complete history taking including ocular complaints was taken from every patient. All the cases presenting with the complaints of facial pain and swelling, toothache, nose block, ptosis, ophthalmoplegia, sudden loss of vision, black astro over palate, lid, conjunctiva, cornea were thoroughly evaluated by a team of physician, ENT surgeons, ophthalmologists, neurosurgeons, and maxillofacial surgeons. We define proven mucormycosis as those patients having clinically compatible signs and symptoms and demonstration of fungi in their tissues or body fluid, either by direct microscopy or culture. Patients who were negative on direct microscopy and diagnostic nasal endoscopy were treated as non-mucor patients by respective departments and were not included in our study. A complete ophthalmic examination, which included visual acuity, extraocular movements, slit lamp biomicroscopy and fundus examination was done. Imaging of both the orbits, brain and paranasal air sinus with or without contrast was done using MRI and CT scan to know the extent of the disease. A complete hemogram, blood sugar, and renal function test if all the patients were done. On the basis of the involvement, we staged our patients as stage 1 showing nose and paranasal air sinus involvement, stage 2 as nose, PNS and orbital involvement, and stage 3 is stage 2 plus involvement of brain. Intravenous liposomal ampho-B was given only after a confirmed microbiological or histopath diagnosis of mucor to all the patients under physician's guidance in a dose of 3 to 5 mg per kg body weight per day. Sinus debridement was done on the ENT side. Patients with stage 2 and stage 3 disease were given ampho-B at a dose of 3.5 mg per ml via retrobulbar approach in the inframedial and the supramedial aspect of the globe after giving 2 ml of lignocaine. Retrobulbar ampho-B was injected once daily for 10 doses and observed. Patients having absence of light perception, total ophthalmoplegia, obvious necrosis of orbital tissue, and worsening despite the above concurrent systemic management were taken up for exentration. Our results showed that out of 110 patients who developed mucormycosis, 36 patients had stage 1 infection, which were treated with intravenous liposomal ampho-B. 74 patients had orbital mucormycosis, out of which 43 had stage 2 and remaining 24 had stage 3. We classified our stage 2 patients as 23 patients who presented within 48 hours of developing symptoms and 20 patients who reported after 48 hours of presenting symptoms. Out of these 20 patients who presented after 48 hours, 13 patients showed improvement while 7 progressed to stage 3. And out of these 7 patients of stage 3, 2 underwent exentration and remaining 5 succumbed to death. Hence, in stage 3 mucormycosis, altogether 12 patients underwent exentration, 10 succumbed to the disease, and 9 survived the disease. Thus, out of 74 patients where retrobulbar amphotericin B was given as an adjunct with intravenous ampho-B, 45 patients had arrest of orbital infection with halting of the loss of visual acuity and subsequent discharge. The survival rate of retrobulbar ampho-B as an adjunct with intravenous ampho-B to patients presenting at an early stage of the disease was 60%, showing promising results. The clinical presentation of orbital mucormycosis is usually orbital cellulitis with proptosis, visual loss, and apical neuropathies. Brunet and Rammert have recommended liposomal ampho-B as a first-line therapy for treatment of the disease along with surgery whenever possible. A case report by Hirabayashi and others where they found that progression of orbital infection was halted and visual acuity was restored with eventual hospital discharge. To our knowledge, clearance of orbital mucormycosis with retrobulbar ampho-B injections have not been previously reported. Our study was done in the ongoing COVID-19 pandemic era, which itself makes it novel. Ours is a multidisciplinary government hospital with a dedicated COVID-19 facility and a tertiary ophthalmic center. Hence, diagnosis of rhino-orbital mucormycosis in the early stage needs a high index of suspicion. To save both the life and sight of the patient, an early diagnosis with prompt, well-coordinated multidisciplinary approach is crucial. Intervention with retrobulbar injection of ampho-B may be a viable therapeutic option in cases of orbital mucormycosis who have presented early so as to halt the infection and help prevent loss of vision and subsequent exentration. These are my references. Thank you.
Thank you very much.
How did you do the retrobulbar ampho-B injection?
As in the preparation of the drug, sir, or?
Delivery. Delivery is important here. How did you deliver
The drug.
retrobulbar
Okay.
amphotericin?
Sir, after taking all the aseptic precautions, we instilled a betadine drop and lignocaine 2 ml on the patient's ocular surface. We also explained the patient about the procedure. And then, with the help of 24 gauge needle, we inserted the needle in the inframedial and some patients in the supramedial aspect of the globe. Initially, we went 90 degrees and we tilted the needle to 15 to 25 degrees retrobulbary, and then we injected 1 ml of the drug.
That's what I wanted, because if you are using the needle, there is high risk of touching and damaging the
globe.
intraorbital
Yeah.
structures, which are very vital structures are there. Instead of that, you could have used a Venflon initial introduction. After that, use the Venflon, which will be more effective for your delivery.
We made sure we could see the proptosis of the eye after putting the drug. Like in retrobulbar, if we go, we could see the eyeball a bit.
Yeah, but
coming
with
up, yeah.
needle, there is a risk of
Yes, true.
the soft structures and the vessels that is
yeah.
there in the retrobulbar area. Okay.
Yeah.
So when you use Venflon, it is smooth and less likely to cause any danger to the structures.
Okay.
Right. And how many at the entry are stage 1 and how many are in stage 3? For my interest, I am asking. Because stage 1, a lot of cases have progressed to stage 2 and 3.
Yeah, no,
Yeah.
in our case, stage 1 disease, we took at only PNS and nose involvement. So those were taken care of by the ENT side. We only managed stage 2, which progressed to stage 3.
Stage 3,
So we
yeah.
had some 20 patients in stage 2 who progressed to stage 3, and those were mainly those patients who presented late in stage 3. So they couldn't be controlled by the injection.
Okay.
Okay, thank you.
Okay, thank you everybody for your patience and excellent presentations. Wish you all the best. Minu Ramkrishnan is here for his presentation on bevacizumab,
Yes, eye drop in patient with.
yeah, in corneal vascularization. Okay, so we conclude the session. Thank you.
Thanks, sir, for troubling you, sir.